Okay, so one of our big perfusion topics is heart failure. So heart failure is a complex syndrome resulting from cardiac disorders that impair the ability of the ventricles to fill with and effectively pump blood. So in heart failure, the heart is unable to pump enough blood to meet the metabolic demands of the body. This chart shows the top 5 causes of death in the United States. As you can see, heart disease is the #1 killer, with all forms of cancer coming in at #2. Many people don't realize that heart disease is such a serious issue because it's not talked about as much in the media. So let's review circulation of the heart. Blood from the body comes into the right side of the heart from the superior and the inferior vena cava. The right side of the heart pumps the blood through the pulmonary valve and into the pulmonary arteries. The blood is then carried through the lungs, where it picks up oxygen, and then returned via the pulmonary veins into the left side of the heart, and the left side of the heart then pumps it out to the body. This is another way to look at it. Although the heart is all together as one organ, it is essentially two completely separate pumping mechanisms. Here is some important cardiac terminology that you should understand. So cardiac output is the amount of blood pumped from the ventricles in 1 minute. Cardiac output normally is regulated by the oxygen needs of the body. So as oxygen use increases, cardiac output increases to maintain cellular function. Effective cardiac output depends on adequate functional muscle mass and the ability of the ventricles to work together. Cardiac output is the product of heart rate and stroke volume. So heart rate affects cardiac output by controlling the number of ventricular contractions per minute, and stroke volume is the amount of blood expelled with each heartbeat. It's going to be determined by preload, afterload, and myocardial contractility. So preload, this is the volume of blood in the ventricles at end diastole, so just before contraction. The blood in the ventricles exerts pressure on the ventricle walls, stretching the muscle fibers. The greater the blood volume, the greater the force with which the ventricle contracts to expel the blood. And this is on the bottom of your slide. This is called Frank-Starling's law. Okay, then afterload is the force needed to eject blood into the circulation. This force must be great enough to overcome arterial pressures within the pulmonary and the systemic vascular systems. So increased systemic vascular resistance, like hypertension, increases afterload, impairing stroke volume, and increasing myocardial work. Okay, contractility is the natural ability of cardiac muscle fibers to shorten during systole. So contractility is necessary to overcome arterial pressures and eject blood during systole. Any impaired contractility affects cardiac output by reducing stroke volume. The ejection fraction is the percentage of blood in the ventricle that is ejected during systole, and a normal ejection fraction is 50 to 70%. Here's a picture that might help you visualize preload and afterload. So preload is the volume of blood in the heart at the end of diastole, at the end of passive filling. Afterload is the amount of resistance in the vascular system that the heart has to overcome in order to pump the blood out. So heart failure develops when the heart cannot effectively fill or contract with adequate strength to function as a pump to meet the needs of the body. So as a result, cardiac output falls, which leads to decreased tissue perfusion. So the body initially adjusts to reduced cardiac output by activating some compensatory mechanisms to restore tissue perfusion. So myocardial hypertrophy is one of these mechanisms. The muscles in the walls of the heart remodel as a way to adapt to fluid volume and pressure increases. The ventricular hypertrophy occurs as existing cardiac muscle cells enlarge, increasing their contractile element and their force of contraction. These mechanisms may result in vascular congestion, hence the commonly used term congestive heart failure. So as these mechanisms are exhausted, heart failure ensues with increased morbidity and mortality. So heart failure is commonly classified in several different ways, depending on the underlying pathology. Classifications include systolic versus diastolic failure, left-sided versus right-sided failure, high output versus low output failure, or acute versus chronic. We are going to focus on just simply keeping it as right-sided versus left-sided failure. So depending on the pathology involved, either the left or the right ventricle may be primarily affected. In chronic heart failure, both ventricles typically are impaired to some degree. So as the left ventricular function fails, cardiac output falls. In systolic failure, pressures in the left ventricle and the atrium increase as the amount of blood remaining in the ventricles after systole increases. And this increased pressure impairs filling, causing congestion, and the increased pressures in the pulmonary vascular system. So the manifestations of left-sided heart failure result from pulmonary congestion, these backward effects, or from decreased cardiac output, the forward effects. So additionally, because of the subsequent increased pressure in the pulmonary system, which backs up to the right side of the heart, left-sided heart failure often results in right-sided heart failure. So on this slide, don't worry about systolic versus diastolic. Just realize we either have an ineffective squeeze, we're not effectively pumping the blood out of the heart, or we have an ineffective fill. We're not effectively filling up the heart in order to pump the blood out. So blood backing up into the lungs causes increased pressure in what is normally a low pressure system. So as a result, there's increased fluid movement from the blood vessels into the interstitial tissues and the alveoli. So this process results in all of our symptoms of pulmonary congestion: the cough, the crackles, the wheezes, the blood-tinged sputum, and the tachypnea. While this blood is backing up into the lungs, the patient is also not getting great forward flow out to the body. So the brain and the body might be hypoperfused, and this can cause your confusion, your fatigue, your cyanosis. So fatigue and activity intolerance are common early manifestations of left-sided heart failure. Dizziness and syncope also may result from decreased cardiac output. The pulmonary congestion causes the dyspnea, the shortness of breath, the cough. Your patient might develop orthopnea, which means they have difficulty breathing when laying flat. So you might see them using 2 or even 3 pillows, or even just sleeping in a recliner at night. You also might note some cyanosis from impaired gas exchange. On auscultation of the lungs, you may hear some inspiratory crackles, and you may hear some wheezes. The crackles are mostly going to be heard in the lung bases because that's where the fluid's going to settle. Okay, so right-sided heart failure. In right-sided heart failure, increased pressures in the pulmonary vasculature or the right ventricular muscle damage impair that right ventricle's ability to pump blood into the pulmonary circulation. So the right ventricle and the atrium become distended, and blood accumulates in the systemic venous system. Increased venous pressure causes abdominal organs to become congested and peripheral edema to develop. So just think, from the right side of your heart, you're pumping blood into your lungs. If you can't pump that blood forward into your lungs, it's going to back up into your body. So as blood backs up into that venous system, we start to see things like dependent edema, JVD, and ascites. Edema develops in the feet and the legs, or if your patient is bedridden, in the sacrum. Congestion of the upper GI tract vessels can cause anorexia and nausea. Right upper quadrant pain can result from liver engorgement. Your neck veins become distended and visible, even when the patient is upright, because of increased venous pressure. So the most common risk factors for heart failure include coronary artery disease and hypertension. And the high prevalence of these conditions makes a lot of people susceptible to heart failure. Some other risk factors include family history, cardiotoxic drugs, like some of our chemotherapy drugs, smoking, obesity, alcohol abuse, and diabetes. The biggest risk factor for right-sided heart failure is left-sided heart failure. So as blood backs up from the left side of the heart into the lungs, the pressure in the lungs is increased. The right side of the heart has to work extra hard to try to pump the blood into the lungs, and eventually the right side starts to fail. A heart attack that affects the right heart wall, as well as any other problems that cause increased pressure in the lungs, can also result in right heart failure. The NYHA classification scale is one of the most widely used. It helps us determine the severity of heart failure. So if a patient is class 1, he or she has mild heart failure, there are no symptoms with increased activity, this patient is comfortable at rest. In class 2, the patient starts to have symptoms when doing normal activities that require some exertion, so like vacuuming or sweeping. In class 3, the patient has symptoms even with minimal exertion, so walking from the bedroom to the bathroom might cause symptoms. And in class 4, the patient has symptoms even when at rest, so difficulty just even when sitting still or laying down in bed. So the main goals of care for the patient with heart failure are to slow its progression, reduce cardiac workload, improve cardiac function, and control fluid retention. So our treatment strategies are based on the evolution and the progression of heart failure. If someone comes in with an acute exacerbation of heart failure, we are going to do something similar to this protocol on the slide. We'll position them upright to try to maximize ventilation. We'll give nitrates to cause vasodilation and decrease the workload of the heart. We'll give Lasix to help get rid of some of the excess fluid that's backing up peripherally and into the lungs. ACE inhibitors to block the renin-angiotensin system, which decreases cardiac work and increases cardiac output. And we'll give digoxin to improve myocardial contractility. So overall, want to decrease fluid volume, decrease afterload, institute a sodium restriction, and run a whole bunch of lab tests to see what imbalances might be present. So our sodium, potassium, and chloride levels provide a baseline for evaluating the effects of our treatment. And then we also measure serum calcium and magnesium as well. So atrial natriuretic peptide and brain natriuretic peptide, BNP, are hormones released by the heart muscle in response to changes in blood volume. So blood levels of these hormones increase in heart failure. BNP levels in particular have been shown to positively correlate with pressures in the left ventricle and the pulmonary vascular system. As the severity of left ventricular failure increases, BNP levels increase as well. This table is from a study I found, which was pretty interesting. They were able to use BNP levels as a predictor of whether or not the patient would die within 6 months. For patients admitted with a BNP level greater than 1500, they have a 35% chance of dying within 6 months. If they're discharged with a level still higher than 1500, they have a 26% likelihood of dying within 6 months. However, it's important to know that BNP levels may be elevated in women and in people older than 60 years who do not have heart failure. So you can't use an elevated BNP alone to diagnose heart failure, but it is one of the values that we look very closely at when we're trying to guide our treatment. Okay, so what other diagnostics do we do? Echocardiography is used to evaluate ventricular function. It can be done either as a TTE, which is a transthoracic echocardiogram, or as a TEE, which is a transesophageal echocardiogram. So for the TTE, the transthoracic, we're just putting the probe on the outside of their chest and looking through the chest wall. In the TEE, which is the transesophageal, we actually put the probe down their esophagus to get closer to the heart to get a good look. But this study, the echocardiogram, can give us a really good look at the heart valves and how they're functioning. And it can also be used to determine the ejection fraction, which is the volume of blood pumped by the ventricle with each beat. So for the left ventricle, we like to see an EF of 55 to 70. For the right ventricle, it's a little lower, around 45 to 60%. We always do a chest x-ray to determine the amount of pulmonary vascular congestion. We can also see cardiomegaly, which is an enlargement of the heart. We do an electrocardiogram, so an EKG, to identify any changes associated with the ventricular enlargement and to detect any dysrhythmias, any myocardial ischemia, or pinpoint any underlying heart attack that might be happening. We also want to look at cardiac enzymes, which I go over in the angina ACS talk. We use a lot of the same drugs for heart failure that we use for hypertension, and this is because the antihypertensive drugs reduce preload and afterload, which is what we also want to do with heart failure. Our patients with symptomatic heart failure often are treated with diuretics, which relieve symptoms related to fluid retention. However, remember that some of the diuretics can cause significant electrolyte imbalances and rapid fluid loss. Patients with severe heart failure are often treated with a loop diuretic. These drugs have a rapid onset of action. They inhibit chloride reabsorption in the ascending loop of Henle, and thus they prompt sodium and water excretion. Their major drawback is their efficacy in promoting diuresis, and this loss of vascular volume can actually stimulate the sympathetic nervous system, which can make our patient more symptomatic. So we need to use them judiciously and closely monitor the response. The thiazide diuretics, these are used for patients with less severe manifestations of heart failure. These agents promote fluid excretion by blocking sodium reabsorption in the terminal loop of Henle and the distal tubule. Our afterload reducing agents are the ACE inhibitors and the ARBs. ACE inhibitors prevent vasoconstriction, so they promote vasodilation, which decreases afterload and ventricular wall stress. The ACE inhibitors reduce the progression and manifestations of heart failure, thus reducing the number and frequency of hospital admissions. They decrease mortality rates, and they can help prevent cardiac complications. In contrast to ACE inhibitors, the ARBs, the angiotensin receptor blockers, they do not block the production of angiotensin II, they block its action. So the pharmacological effect is very similar to what you see with your ACE inhibitors. They are also used in heart failure to slow its progression, they reduce manifestations, and they also can help prevent those cardiac complications. One class of medications that you will not usually see with heart failure is beta blockers. We always think of beta blockers when we think of heart problems. However, while our beta blockers improve cardiac function by inhibiting SNS activity, They also reduce the force of the myocardial contraction, which can actually worsen symptoms. So if they need to be used, we use them in low doses and we use them in combination with our ACE inhibitors. Let's see, human BNP. These are used in cases of acute decompensated heart failure. So Natracor is the most common. It's given IV only, so it can only be used in the hospital, but it reduces pulmonary pressure by causing loss of sodium and water, and it also causes vasodilation. Inotropic agents are used judiciously in symptomatic heart failure. Digitalis has a positive inotropic effect on the heart, so it increases the strength of myocardial contraction. It also slows conduction through the heart, which increases ventricular filling time, but it does have a narrow therapeutic index, so therapeutic levels are very close to toxic levels, and it needs to be carefully and very closely monitored. Vasodilators, these relax the smooth muscles in the blood vessels, causing dilation. Arterial dilation reduces afterload, which reduces myocardial work. Venous dilation reduces venous return and preload. Pulmonary vascular relaxation reduces the pulmonary capillary pressure, which allows reabsorption of fluid from the interstitial tissues and the alveoli. So that helps us get the fluid back out of the lungs. When we have a patient with acute heart failure, we definitely want to use a team approach. Typically, when the patient comes in, the ER doctor runs the show initially and then admits the patient to cardiology services on the floor. Respiratory therapy can provide whatever breathing treatments the client might need. And if the hospital stay is prolonged or the patient is having a hard time recovering from an acute exacerbation, they will often be referred to what's called cardiac rehab, which can be done on an outpatient basis. Nutritional services are also really helpful in teaching the patient how to maintain a heart-healthy diet. So heart failure is a chronic condition requiring active participation by the family and the patient for effective management. It's important to educate the patient on the disease process and the effects that it can have on the patient's life. We want to teach the desired and adverse effects of prescribed drugs, monitor for the effects, and talk about the importance of compliance with the drug regimen to prevent acute and long-term complications of heart failure. We want to teach about diet and sodium restrictions. Give some practical suggestions for reducing their salt intake. If they have internet access, they can go to the American Heart Association website for lots of materials and recipes. We want to recommend exercise to strengthen the heart muscles and improve their aerobic capacity. We also want to stress the importance of keeping scheduled follow-up appointments and monitoring disease progression and the effects of therapy. It's nice if you can provide referrals for home health care and any household assistance like shopping, transportation, housekeeping, as indicated for your client. Referrals to community agencies such as local cardiac rehab programs, heart support groups, or the AHA can provide the patient and the family with a lot of additional materials and some psychological support.